Welcome. This is How Physician Leadership Can Create Culture Change. I'm going to introduce Dr. Harry Krulewitch. He's the assistant professor in the Department of Family Practice at Oregon Health and Science University, and he's a board-certified geriatrician. He's the past president of the Oregon Geriatric Society, and he's been a geriatrician in private practice in Portland since 1993. Welcome, Harry Krulewitch.
Good morning. Our previous webinar discussed the process and structure that can go into the contract for the medical director to have more effective leadership skills, specifically by having rounds and IDG and care conferencing structured to the obligation to function in your facility, as well as designating a nurse from his or her practice to liaison with an RCM in your nursing home to create relationships that can lead to more effective collaboration. Why are we putting this in place? Well, we basically want to focus on how you can improve your QAPI programming, and we want to use principles of patient-centered care, palliative care, and chronic disease management, which are really cutting-edge goals now that are being recommended for all geriatric care planning. Let's look more specifically then at what we're going to do with this team that you've created. When you look at the QAPI that we tackled at the Avamere Pearl facility, it was readmission. The most important thing that you're going to do once you have your team in place and you identify a QAPI is actually to do some literature review. It's important that whenever you develop a plan, that the team, not just the doctor, but the team that you put together focuses on the intervention, because in the process of working together, they will also learn how to implement the problem together. But you also want to make sure that they're working with not opinions or marketing goals or the ideas of any particular individual, but they're doing best practice interventions based on a review of the literature that you can get at a university or hospital library. With readmissions, we looked at a number of key articles from national review and task forces. One of the articles that I was able to get looked at hundreds of nursing homes, identifying what components were associated with excellent community-based long-term care. The top aspects of care that had 20% or more of the facilities agreeing that these were critical were these elements: linkage with the hospital, having an effective IDG, having end-of-life expertise in the IDG, having what they call holistic but person-centered care, which basically means that the family and the patient's preferences are deliberately sought out and integrated into the care plan, not just the evidence-based interventions of the doctor. That there's a commitment not just to curing the patient, but to pain and symptom management. And that the emotional needs for the patients and family caregivers are addressed by professional staff in a deliberate part of the care plan. This all has to happen within that IDG process. So when we meet on a weekly basis and we're doing the chronic disease management plan, I mentioned in the previous talk that some patients will be identified as having a risk of being poor outcomes, possibly dying, needing hospice care, having multiple comorbidities, all of which predict higher mortality rates and decline in function, again, which can predict earlier deaths. If we're going to be addressing these types of patients and not just try to treat their care plan, we went through the literature. This particular slide addresses, from a national task force, all of the elements that should go into a care plan. And we use this at OHSU in a dot phrase, in Providence, also in an EMR system, and in all of your hospice organizations. These are the charting elements that a good care plan has to have, and identifies who's going to be doing it, when it's going to get done, and then you can review it on a regular basis. So this gives us a structure during a care conference and a care plan to make sure we're addressing all of the elements of a quality palliative care plan from a patient-centered perspective. I'm not going to go into any of the details of this slide because of the time, but on a number of these slides that are copies of National Task Force review plans, if you want more details and information, please contact Health Insight to get in touch with me, and I'll be glad to get you the references for some of these slides. In this slide, from another National Review article that was a seminal review research article over 10 years ago, these were elements of patient care in geriatrics that better predicted if someone would either survive or have a good outcome from a rehab center, and also could predict who was much more likely to go to a nursing home or even die within a year. Notice that none of these syndromes are associated specifically with any particular illness, and that's critical in geriatrics, and we're beginning to teach that to all of our doctors. While it's still appropriate and professional to treat each disease, if you only treat the specific diseases and don't address these issues, it now is really unethical and unprofessional, because these combinations of syndromes are much more likely to predict who's going to live, thrive, or die in the next year. And your IDG care plan needs to have a sense with every patient who's at risk from clusters of these syndromes. In fact, what we would do is, if we had patients where these syndromes were clustering, we would then realize those patients might need a palliative care conference if they weren't medically improving, no matter what the specialist said about the treatment of their specific diseases. In this review slide from the American Geriatric Society, these are now guidelines for chronic disease management from the AGS that was part of a national task force. Notice, I'm not going to go into detail, but notice how many of these guidelines have nothing to do with specific drug treatment, surgical treatment, rehabilitation treatment, but focus on the preferences of the patient or family. We're talking about a chronic disease management guideline from a national physician task force that basically says identifying and inquiring about the preferences is fundamental to good care planning. And yet, as I pointed out in my first talk in the previous webinar, physicians are not trained to effectively integrate or identify patients' preferences. The current language that we're using for identifying patient and family preferences is called goal-centered care, and I'll be using that language in further slides today. In predicting readmissions, at the Pearl, I did a literature review over 10 years of journal articles at the university and at Portland Hospital, and I looked for extensive quality publications. These were the readmission results that I found from a number of articles that I presented to the management team that also matched a lot of what they were getting from national workshops that they were going to. I'm not going to go into detail because this talk today is not about reducing readmissions, but I wanted to show you how important it was to have this extensive detail. Once you have a process in place, now you need the content to get to the outcomes you want. That content won't come from people's opinions. It's got to come from identifying in the literature best practice research that you know other quality organizations have published and documented, and that you're not recreating the wheel or going off on a tangent that's unfounded. And now we come to the goal-oriented care. If you're going to have a care plan that's going to implement goal-oriented care, then you do need to do these particular steps. You're going to have to define those goals by the individual and their family, not the provider. It's not, are you taking your blood pressure pills, but do you want to address your blood pressure, or maybe you want to address taking care of your granddaughter. If the goal is taking care of the granddaughter, does having good blood pressure have anything to do with it? Maybe it does, maybe it doesn't. But if you can't tie the blood pressure into taking care of their granddaughter, then you are not providing goal-oriented care, because that person has told you their goal is to go home and take care of their granddaughter. And you better make sure that all of your care planning focuses on that goal, not your doctor's medical treatment. Consequently, your best determined goals are going to be through collaboration and not evidence-based care. Giving that patient a number of drugs that reduce blood pressure because the evidence says those drugs are really good is not the key. It's going to be, if they want to go home and they're a grandparent taking care of a granddaughter, can they bend over and tie her shoes? Can they cook her food? Do they know how to manage money? So that's going to require other disciplines that have nothing to do with the doctor. If you don't address that in a collaborative way, you've lost that patient and that family because you're not addressing their goals. Now, the goals are going to be defined on the strengths, resources, needs, and values of the patient. That is another special talk that I can give, and I won't go into detail today, but identifying the strengths and resources, needs, and values of the patient have more to do with anthropology, sociology, psychology, essentially the goals of the older adult and the stages of life that they're going through and the tasks that they're trying to accomplish. It has nothing to do with medical treatment. Consequently, the motivation and participation of the patient and the family is based on your staff's ability to agree and collaborate on their goals, not on you selling them on your treatment. And success is going to be based on the family and the patient and the caregiving team all achieving the goals that the family has selected. The principles of goal-centered care, then, are that the locus of control is restoring autonomy. Autonomy has been identified in a number of studies in psychology and anthropology and sociology as a core feature of quality aging. By giving the family and the caregiver the commitment that their goal is something the whole team is going to work on, they're empowering the family and the patient that their goals mean just as much as your treatment goals. And in fact, your treatment goals are integrating their personal life goals into the plan. So the choice and participation of the family and the patient is giving them a new sense of hope that they're not just being inundated with medical treatments and feeling that they're more overwhelmed, disabled, impaired, and sick. Consequently, how you communicate with the family those goals is much more vital than what you're communicating. As I said before, you may want that patient to change the blood pressure pills they're on, but if the patient says they want to become more active so they can dress that granddaughter, and your physical therapy team teaches them how to get in and out of bed and take the granddaughter to the bathroom and cook for her, they're going to be more motivated to change their blood pressure pills than if you ignore their goals first. And the PRIDE is a model that we're not using at the Pearl, but it is in the literature. If you're interested in acronyms, instead of using SOAP, you're using this model because it more highlights problem solving, collaborating, goal seeking, and establishing reward using behavioral interventions instead of the typical SOAP model for how you go about your day-to-day care plan in the nursing home. So let's look a little bit more at what are the leadership skills that I need as a doctor with the patient, with the family, and most importantly, with the other disciplines, nursing, social work, therapy, rehabilitation, speech, nutrition. Look at the left side model. These are the medical treatment models. These are the skills that I learned over 10 to 15 years as a doctor. I was learned that it was okay to judge, to blame others, to say who's right or wrong. I was protectful of my turf. Why is the urologist being called? I can do that. Why are you doing that? I should be in charge. You know, am I right? Am I wrong? Who's at fault here? Why are people disagreeing with me? Why can't you just do what I'm telling you to do? Look at the patient-centered model. Look at the type of tone that the leader is here. Are you accepting other people have suggestions that might be useful, even if it's something you don't agree with or it's not from your discipline? Is it practical? Is it working, even if it isn't what you want to be doing? What are the facts of the situation as opposed to the evidence? What's the bigger picture? What are the goals that the patient and family have? What are my choices and their choices? What's going to be useful? What can I learn from a nurse who's telling me that she's got a better idea? What is the person feeling? If they have emotions that are suggesting that they're angry, upset, bitter, discouraged, they're not going to listen to anything that we're telling them. Is someone spending time understanding and validating what their emotional needs are? And why are we trying to cooperate? What is our goal? What's our intention here? Is it to be right, to be in control, or is our intention to be of service and to help this family get back on their feet? So in the end, To be more clear, let's look at the paradigm we're creating here. In the medical-centered model, the traditional model, experts are in control. The medical treatment is defining everything that's being done. It's very autocratic. The greatest experts are in the most control. It's authority-based. You're solving the problem. Everyone's quite happy with this approach. It's content-based. It reduces everything to specific protocols and treatments, and the person follows what they're told to do, so they're objectified. The patient-centered care model and the chronic disease model, the geriatric quality task forces from our leading universities are now recommending, is saying this is not the way you solve the problem. What I'm suggesting is first you have to have a team in place that knows how to do person-centered care, which we discussed in the previous presentation. And once that team is in place, they need to be trained with these type of leadership skills. They're interactive. They're patient-centered. They're concerned with their intentions and the goals of the patient and family. They work together. They learn together. They share decision-making. Different people can be in charge. It's process-based. You're a system. It's collaborative. You're partners with other people despite different levels of training. And you treat the patient, the family, as the subject. They're making decisions. They're setting the goals. They're setting their preferences. You're working with them and for them, not upon them. In the end, what kind of team leader is your physician? Is your physician demonstrating these attributes or not? And you know, I know you know, and you know you know. It's not unusual for an executive to take me aside and say, Dr. Krulewitch, what are we going to do with this medical director? He or she really is a good doctor, but, and you know where they're going. So, again, not only do you need to have a doctor willing to do this, but what management system is reinforcing patient-centered care? We talked about this in the first talk. If you're not willing to create the structure, the contracts, the staffing, and the resources for that doctor to function, even a physician trained in patient-centered care won't succeed. Your care plan won't succeed. You're undermining it. And there are other reasons it could be undermined. Markets connects communities and family systems. The patients themselves and the doctors are involved in many different reimbursement models, none of which may be paying for some of the things we're trying to do. And more importantly, the language can annex autonomy. Treating patients with words that suggest that they don't have the right to make decisions, that they don't have the right to be respected, that you model that disrespect and that lack of control as a doctor with the rest of the team undermines the whole patient-centered approach. So having a common language is part of the training that I had mentioned in the first talk. The whole team needs to get trained in patient-centered care so that they have a common language that's empowering and enabling and respecting of the patients and families, including issues that look at race, gender, culture, religion, so that no one is inadvertently making comments that undermines people's sense of self-respect. And lastly, freedom of choice is not ownership. I know here that this is a controversial concept, but giving people choices is not the same as telling them that they have a role to play in their recovery and that you're going to pay attention to their choice and not push your choice of treatments onto them as a family or patient. So in the end, real culture change is not just about throwing protocols for QAPI into some process and expecting it to pop out the other end after 3 months. You cannot have real culture change without management, leadership, administrators, or directors of nursing, and the doctor buying in. The rest of your staff is looking to you for role model leadership. And at the very top, there has to be real buy-in. Second, this is hard stuff. Your own values may be in conflict with what we've just talked about. Your own approach after years, like a doctor coming out of a residency program, is going to be challenged because we're talking about people that are not the owners and not the doctors and not the lead directors of nursing having a higher level of participation in decision-making. And this is a very difficult thing to pursue. How do you set limits around it? How do you set boundaries around it? But how do you promote it? It requires ongoing training at the individual and group level. And lastly, there needs to be group self-reflection. I would always leave a few minutes at the end of every IDG for telling the group, how did we do it? People say, well, we're out of here. We got to get a pizza. And I would say, sit. How did we behave today? Did you feel good about how we did things today? And people might say, I really liked how she spoke up. I liked how you spoke up. I didn't like that you ignored her, or you spoke too long about that drug and you missed that issue. These are real important parts of the meeting. Self-reflection gives the team a chance to reinforce the kinds of collaborative skills that you're trying to build and tells them that their team behavior is valued. The most important thing I'm trying to get at is if you are not empowering and respecting each other, how can you empower and respect the residents and families who are dealing with chronic and ongoing acute disabilities and impairments and are trying to recover from complex medical situations in the geriatric environment? It's an ongoing process of personal growth for your team and your professional, but I can tell you that if you do this, your staff are going to feel like they are being treated as real professionals. There's going to be a chance for much more retention. Nurses want to be able to do what they're trained to do and not just follow orders and implement care plans. They want to have a meaningful role in the healing and growth of their families and patients. The other professionals in rehabilitation also want to have a higher sense of performance and engagement with patients and families. So in the end, going through this process will not only enhance retention and organizational performance, but I will tell you, you'll have happier employees. And I can tell you personally, I've grown a lot as a man, as a father, as a husband, as a doctor, because I've learned how to respect and listen and appreciate the roles of other men and women from different cultures and disciplines and areas of the professional team, and respect and trust what they can contribute to my patient's care. Thank you.